Right, thank you. Some things don't change, unfortunately. Anyway. These are my learning objectives. So far, we've been mainly focusing on failure of anaesthesia, where there's been an intention to give a general anaesthetic. This lecture is going to focus on cases where there was no intention to give an anaesthetic, and normally, in most cases, a muscle relaxant was given before a hypnotic agent. So in actual fact, it's rather than being accidental awareness, it's probably unintended awake paralysis is probably a more accurate description. Certainly, it almost invariably has major implications for patients and frequently for the anaesthetist involved too. As we've heard earlier this morning, just to recap, the instance of drug errors is at least 1 in 140 anaesthetics. The probable real instance is probably much higher. Fortunately, drug errors leading to awake paralysis are much rarer. Many errors are due to slips or lapses, but Reason's classic Swiss cheese model, lining up of the holes to sort of to stop the protective barriers so that errors manifest as patient harm is very common to many of these cases. So there are 3 types of drug errors that occurred in NAP5. All right, there's one drug common to all 3 drug errors, and I'll give you a clue. So, anyway, the most common ones are the syringe swaps, simple syringe swaps when the anaesthetist picks up the wrong syringe. Close behind that, there are drug labelling errors where the contents of the syringe are different to that indicated on the label. And finally, drug omission, where there's a failure to draw up the intended drug. There is a 4th type of drug error that can lead to awake paralysis, and that's namely when you get injection of retained muscle relaxant in dead space of a cannula or an extension. These cases didn't appear in NAP5 because there wasn't an intention to give general anaesthesia, so they were excluded from NAP5. But these are the 3 cases with 3 types of report we're going to concentrate on. So there were 17 reported cases consisting of 10 syringe swaps, 6 drug labelling errors, and 1 omission error. These arrests could occur at any time of the day, typically in low-risk patients, and the period of perceived paralysis was often very short. Just to recap, as it's after lunch, just remember this is the classification we tend to use, one of the major classifications, and it's class 4 and class 5. I don't know if you can see it at the back, but class 4 is paralysis, and class 5 is basically paralysis with pain. So there were 10 syringe swaps. 9 of the 10 occurred when there was administration of a muscle relaxant before a hypnotic. There was one exception, and that was in an obstetric patient who had an epidural in situ, and there was an intention to top up the epidural with lidocaine, but accidentally that was given intravenously, a large dose of lidocaine, and the patient was aware of the subsequent resuscitation and intubation. But the other 9 cases were all failure to give a hypnotic before a muscle relaxant. I could have presented 17 case scenarios, but I'm going to be pleased, I'm just limiting it to 4. The first one is first syringe swap was for a minor case, and the anaesthetist had been harassed, a busy list, changes of trainees, changes of patient order, the usual story, and he mistakenly gave suxamethonium instead of ondansetron before induction of anaesthesia. The patient was aware for 30 seconds or so and became extremely distressed, reported being paralysed, unable to breathe, and a sense of impending doom. In the post-operative period, this patient was very angry and litigation has started. So a second syringe swap, it can happen just as often happens with small syringes, it can also happen with big syringes. And this example is an illustration where a very sick patient having an urgent laparotomy was actually being looked after by 3 anaesthetists. That may or may not have been a factor. And unfortunately, one of the anaesthetists picked up the cefuroxime and gave it instead of the thiopentone. On intubation, the patient became very hypertensive and tachycardia. The error was realised, and fortunately, the patient has had no long-term sequelae. The patient was very ill at the time of induction and made a good recovery, and because he was delighted with the hospital experience, he was very positive about things, so very forgiving. So the second type are these ampoule labelling errors, and drug emission errors. The top 6 are all ampoule labelling errors, and the bottom, 6 of them are, there's one drug emission error, and that was thiopentone, where water was given instead of thiopentone for rapid sequence induction. This again was a 2 anaesthetist list, or a pair of anaesthetists. There was a syringe labelled with thiopentone, and the second anaesthetist thought the first anaesthetist had drawn it up, but obviously not. So this is one of the commonest, this is a common drug labelling error. There was an anaesthetist intended to give fentanyl to a patient undergoing general anaesthesia, but it quickly became apparent when the patient's arm dropped off the bed and the patient stopped breathing that it hadn't just been fentanyl that was given, and so the patient realised what had happened, so he rapidly induced the patient, and it reassured the patient, and it was clear that in retrospect, that a loose ampoule of suxamethonium had been placed in the tray next to the fentanyl, and it was noteworthy that there'd been a recent change in hospital policy. Previously, the suxamethonium had always been kept in boxes, but because of concerns that it was being left out of the fridge too long, they changed the policy to just having a single ampoule out. I think they reversed the policy thereafter. Right. The second drug labelling error. This is a patient undergoing orthopaedic surgery. There was an intention to perform an interscalene block and then proceed with general anaesthesia. Unfortunately, the patient had difficult venous access. The anaesthetist was harassed, and when he reached up to pick up his midazolam, he inadvertently picked up his atracurium, and then follows a panic and acute distress in both people in the room. And then it transpired that it had been a busy list. I think there'd been a late start due to various issues, and everyone was stressed. But again, this patient graciously accepted the apology, and there was no long-term sequelae. Right. What I'd like to point out, we've heard about the classification of the NAT5 reports this morning. Class A are the sort of definite cases of awareness. These are the possibles, and these are the awake paralysis. These are the various measures to assess the psychological sequelae or the impact on the patient. And what you can notice is that the sequelae, but whichever system you use, whether it's Michigan, Wang, or MPSA, the sequelae are worst in the patients having unintended awake paralysis. So it's the sequelae are, although it's the patient's perception is very similar to ARGA, but worse. So the panel, we assessed these 17 cases, and we didn't agree on everything, but we did agree on one thing. We agreed that 100% of the Class G cases were preventable. There was sort of consensus about that. Not surprisingly, the quality of care was never deemed to be good before the ARGA. However, despite the fact that we often said that the quality of care was very poor before ARGA, the quality of care after ARGA was often high. So, the instance of unintended awake paralysis, what did we find? Given that there were sort of over 1 million cases involving neuromuscular blockade per year, the instance of reported cases is relatively low. A majority of drug errors are causing awareness due to simple syringe swaps of similar size or similar coloured fluids. It's noteworthy that although thiopentone appeared 3 times in the 17 cases, once in each category, propofol didn't appear in any of these drug swaps. Interesting. Recurring themes I think we've mentioned on our way down, and lack of vigilance and having messy trays was also, we felt, often contributory. Strategies to reduce error. I think we all need to accept that we're prone to making errors and need to develop robust individual mechanisms to protect ourselves. And I think most of the panel of NAT5 have changed their behaviour since the starting of this project. What about these 2 contentious issues? Probably the first of these will be very controversial. The panel we had a lot of discussion about this. There have been studies done about double checking of ampoules and labels. For this to be done properly, it has to be done at the time of drug selection, drawing up, and administration. And people have done studies on this, and the evidence is inconclusive. Similarly, pre-prepared drug syringes and scanning, that they are a potential major step forward, and certainly my trust uses this policy, but they're not infallible. The scanners sometimes break, and it's certainly potentially the future, but there are major cost implications. Strategies to reach error. Often hospitals choose the cheapest ampoules rather than the most sensible, and in my institution we often have problems with heparin and protamine being in identical syringes. And we need to sort of pay greater attention to the organisation of our workspace. Similarly, the panel felt we ought to avoid overcomplicated anaesthetic techniques and avoid unnecessary administration of drugs such as antiemetics, antibiotics at the very time of induction of anaesthesia. We also thought that anaesthetic conduct after drug error was very important. There were some scenarios I didn't have time to explain them where the anaesthetist tried to reverse the atracurium after giving, without inducing unconsciousness, and those patients were particularly badly affected by the process. So the first priority is highlighted in red. If you do have this sort of problem, if you are unfortunate to have this problem, induce unconsciousness as soon as you can. And during that time, you must, verbally reassure the patient that their life is not in danger. Okay, thank you very much.